Hi everybody, my name's Jenna Minton Lonjouet and I'm with Santa Ana College Wellness Program. Today we're going to be going over the back, so injury prevention and some treatment for back-related injuries. When we talk about the back, we're going to talk about the cervical spine, the thoracic spine, and the lumbar spine, so the entire spine when we're talking about the back. A few things about me, okay? The alphabet soup after my name. I am a licensed physical therapist assistant in the state of California. Got my Master's of Science Kinesiology Human Performance, and I'm a certified strength and conditioning specialist. I've been with Santa Ana College for about 5 years now, working in the wellness program and also helping run PT in the mornings at the Basic Fire Academy with all the fire recruits. I also worked in outpatient orthopedic physical therapy for over 10 years. We specialized in post-surgical knees, shoulders, backs, hips, everything you can think of. We contracted with the local police and fire department, so saw a lot of police and firefighters, as well as the local high schools and colleges, so a lot of sport-related injuries. So I've been working in the field for a very long time. Last but not least, I always like to point out, my father worked for the City of Torrance Fire Department for well over 30 years, and my husband is currently a fire captain with the City of Fullerton. So grew up in this environment, still living in it, so really enjoy working with the fire department. So let's go ahead and get started with the back. Okay, so some stats. According to the NFPA, an estimated almost 61,000 firefighter injuries occurred while on duty in 2021. 32% of those occurred at the fire ground, 13% during training, and 21% during non-fire emergency incidents. Strains, sprains, and muscular pain injuries or musculoskeletal disorders made up approximately 45% of the fire ground injuries, 58% of the training, and 52% of the non-fire ground injuries. Okay, so strains, sprains, and muscular pains. The neck, the thorax, and the trunk combined made up 22% of those injuries. That's excluding upper extremity, lower extremity, head, internal injuries. Okay, so 22% of those injuries. What does that tell us? Okay, injuries, physicality, it's part of the job. Naturally, firefighters have a high risk of injury in comparison to other public servants and the private sector. But that also tells us with strains, sprains, and muscular pains, there's a lot of opportunities to lower that risk of injury, okay? This isn't taking into consideration fractures or dislocations. What this tells us is if we're, pulling muscles, tearing ligaments, things like that, there's a chance that we can lower that risk when we step back in time. Is there range of motion issues? Are there strength deficiencies? Are we not moving with proper mechanics? Okay, so again, this isn't talking about our acute catastrophic injuries of burns or crashes or anything like that. These are our strains, sprains, and muscular pains that we have the opportunity to try and reduce that risk and lower those numbers down. Why does that matter? Well, first of all, firefighting, a lot of repetitive motions that get extrapolated over time. So we're talking getting in and out of the rig, your interaction with the rig, pulling hose off, getting tools out, okay? Lifting objects in patience, ventilation and forcible entry. Again, very repetitive motions. We do these motions we're trained to do them in a particular manner, in a certain way. Hand tools, maneuvering ladders and hose lines, charged hose lines, number one event where injuries occur, okay? So charged hose lines, crawling in stairs, or overhaul. Again, when you think about how many calls you go on in a day over a period of a shift, you're there for 48 hours, probably more than 48 hours, okay? Extrapolate that over a year, over 30-year career, okay? We are talking about repetitive movements over and over again. I got my engineers that come in and out of the rig on the same time, my captains in and out of the rig at the same time, always pulling hose the same way, things like that, always throwing ladders, okay? These repetitive movements will add up over time. So then again, if we're talking about inefficiencies or poor mechanics, we can look at when a catastrophic injury happens, and then we can walk that back and say, well, that didn't just sporadically happen. That was because we were lacking range of motion. We didn't have the proper strength. We were using poor mechanics. Okay, so again, repetitive motions over time, those micro traumas will add up into a catastrophic injury. Risk reduction. Okay, we're going to give you the education on what we're talking about today. Again, for the back, we're going to give you what's important. I don't expect you to know all of this. Okay, this isn't your job to know all this, but we're going to give you what's important, what's reasonable for you to know, so you can use those tools and implement them in your daily life to, again, try and reduce our risk of injury. We want to look at longevity, okay? It's about making it to retirement, but not just that, making it beyond retirement. We want to be injury-free and comfortable and be able to do the things that we're talking about once we're retired. Hang out with our grandkids, go on our fishing and hunting trips, go traveling, whatever it is you want to do, okay? It's about getting through your long career and enjoying your retirement. So we're going to get into some anatomy, okay? Some of this is basic, some of it's going to be review, some of it's going to be really in-depth. Again, not expecting you to know all of this or necessarily remember all of it, but we'll go through the basics so we can lay a foundation to build upon what we're going to talk about later. So there's 5 sections of the spine. We have our cervical spine, which is 7 segments. Thoracic is 12, lumbar is 5, the sacrum is 5 fused bones, and your coccyx or your tailbone is 3 to 5 fused bones. We have here, okay, our spine model. So again, our cervical, our thoracic, our lumbar. This is our sacrum and our coccyx, okay? There are 3 natural curves to the spine. We have these lordotic or frontward facing curves, kyphotic or these back facing curves, okay? And then there's technically a scoliotic curve, which we don't think of as being a good thing, but we naturally have a slight lateral bend in our spine because we have a dominant side or the other. When they become really large scoliotic curves, that's when we start to look at some more interventions, okay? So 3 natural curves. These curves, we want to keep these curves, okay? We're not just stacked one vertebrae on top of each other. We want to keep these curves because that is how the spine is supposed to sit. We get these curves as we begin to crawl as babies. That's how they develop, okay? But we're not just straight up and down. We have these curves, so we're going to try and keep these curves. They're going to be important later. Some functions of the spine include mobility and stability. Again, we're moving through the cervical spine, the lumbar spine. We're very stable through the thoracic spine. Attachment sites for tendons and muscles and ligaments, okay? Lots of tendons and muscles and ligaments along the spine, along with what attaches to our spine so we can get some more global movement. It's a shock absorber and a load distributor, okay? So these, in particular, the intervertebral discs, okay? We are going to absorb shock as we're moving about in the world, and also as we place load on it, it gets distributed out. And lastly, a nervous system protection. So all of the spinal nerves that come out the side, along with our spinal cord in the back. Here's pictures. We all like pictures, right? Okay, so here we go. We've got the body, cervical spine, thoracic, where the ribs insert, and lumbar. From the front, from the side, you can see our natural curves here. And more importantly, we're going to look at each segment a little bit individually, why there's some different characteristics, okay? So if we look at each section separately, we have our cervical, thoracic, and lumbar, okay? Again, 7 cervical, we have 12 thoracic, and 5 lumbar. You can see here the major differences, okay? Very, very small at the cervical spine, a little larger in the thoracic, and very large in the lumbar area. Why is that? Well, we don't have a lot of weight we have to carry in our cervical spine, okay? Just the weight of our head, generally between 10 to 15 pounds, averages about 12. Some people a little bit heavier than others, okay? So not a lot of weight has to be placed on the cervical spine. In comparison, a lot of range of motion, a lot of twisting, things like that is going to make up the shape of this. Thoracic, in particular, again, not a lot of movement per se, but we have rib insertions on the side. Lastly, the lumbar. The lumbar vertebrae are very, very large because it takes the weight of our body and our upper body and anything we place on it. So you're thinking about anything you're carrying, SCBAs, hose bundles, stuff like that. All the weight gets put through the lumbar spine, which is why the vertebral bodies are so much larger. They're larger a little bit more in the front than in the back, which is going to be important when we talk about discs later on. And the joints in particular, when we look at these, they prefer flexion and extension and lateral, not particularly twisting, in comparison to the cervical spine, which prefers twisting more so, okay? So those are our 3 different segments. If I were to take a segment out and we were to look at it from the top, this is what it looks like, okay? So we have our spinous process in the back that sticks out through here, transverse processes on the side, Articular processes are where one segment meets the next. We have the spinal cord in the center, the spinal nerves that come out the side. Okay, we also have some vascular structures that run up and down. And then importantly right here, this is our intervertebral disc, okay? I want you to think of it like a jelly donut, all right? If this is the outside of the jelly donut, our annulus fibrosus, the inside is our nucleus pulposus, that's our jelly, okay? This is going to be important when we talk about disc bulges a little bit later on, but this outside annulus fibrosus is a harder fibrotic tissue. The inside is pretty much all water. Okay? When we're born, it's about 90% water along with some collagen. As we get older, it starts to decrease. The average adult, about 60 to 80% water. As we get into our later decades of life, that begins to decrease as well. Okay, so this is our jelly donut. This is our intervertebral disc. If I were to put them one on top of each other, this is what they look like, okay? So again, our vertebral bodies are intervertebral discs. These superior and inferior articulating processes, okay, this is where one meets the other. It creates a facet joint. Again, these are what create our movement. Each one of these joints moves independently of the other, so small movements all add up between each joint, which gives us our larger global movements, okay? Lastly, we also have the intervertebral foramens, which is again where spinal processes or spinal nerves and vascular structures come out. And this is what they again look like stacked on top of each other. This is our shoulder girdles, what we want to look at right here. Okay, head, neck, we got our ribs, but this is the shoulder girdle. Our shoulder blade and our clavicle make up our shoulder girdle, and that's what attaches our arm to our upper body. The shoulder girdle is going to be important when we talk about the influence it has on the cervical spine. Okay, so all of these muscles are going to attach to it. Our shoulder blade has a few different ranges of motion. Okay, we can protract, retract, has upward rotation, downward rotation, elevation, depression, and tilting. Okay, so this shoulder blade and all of the muscles that attach to it are also going to attach to our trunk, which will have an influence on our cervical spine later. Okay. Lastly, we have the pelvic girdle. We can't really talk about the low back without talking about the pelvic girdle and the hips, okay? So the pelvic girdle is made up of two bones that meet in the back at the sacrum. The hips themselves, okay, are made up of three fused bones. So we have our ilium, our ischium, the bone that you sit on, and our pubis bone in the front, okay? So all of those are fused together. The pubic bones in the front meet at the pubic symphysis. We have the obturator foramen, this large hole. A lot of nerves run through there. Our acetabulum is where the head of the femur meets to make our true hip joint. We have the pelvic inlet for a lot of our organs. And then most importantly, which has the largest influence, is back here where the sacrum meets the pelvic girdle. This is our sacroiliac joint. You'll hear it a lot, SI joint. This joint has a huge influence on our low back. Anything our hips and our pelvic girdle do as we move and we walk and all the things that we do will go through and translate through the sacrum and, again, translate into the low back. So can't really talk about, again, the low back without talking about the pelvic girdle and the influence it has on it. So we're going to go over some common injuries of the back, okay? The most common that you're going to see are sprains and strains. This is your, I bent over to pick something up and I pulled a muscle, that kind of stuff, okay? I woke up and my neck's a little tight. Those are your sprains and strains. So we're talking again about ligaments, tendons, and muscles. The disc, we're back to our jelly donut, okay? There's four different phases of that are disc or stages that our disc bulges and herniations can come in. A bulge and herniation are the most commonly heard, although they are different. So they're kind of used interchangeably, but they are different. So it starts with a compression. So I push down on my jelly donut a little bit, okay? A bulge is next. So now it's pushing out against the side of the donut. The jelly's pushing out against the outside of the donut, okay? A protrusion would be next, and then lastly, a herniation. That's where the actual jelly from the jelly donut starts to push out, okay? So again, bulge and herniation are used most commonly, used interchangeably, but technically different. Bulges are smaller than herniations. Spinal stenosis is the narrowing of the spinal canals or the vertebral foramen. It can occur for a lot of different reasons, but it's anytime something's going to narrow, and we're going to get some associated injuries with that. Generally, we start talking about nerve compression, but spinal stenosis is the narrowing of any of the holes or the canals. Spondy-related conditions. All right, for my Scrabble and Words with Friends people, okay, we have a few different spondy-related conditions. Spondylosis is just general degradation. It's just wear and tear of the bones. In this case, we're talking about the bones of the spine. Spondylosis was then if we get wear and tear of the bones, and then they start to fracture. We'll get fractures along the pars, okay? That's part of the bone, part of the vertebral body here, the vertebral arch, where it starts to fracture. What then happens is we get spondylolisthesis. The actual vertebral body will begin to slide and move, okay, which we don't want. We want them to stay in place. So we get a fracture, the fracture breaks off, and the vertebral body will actually start to slide. That's spondylolisthesis. We're talking bracing, possible surgical intervention. Lastly, we have spondylitis. That's inflammation of the joints and where the bones meet, generally due to either autoimmune disorders, rheumatoid arthritis, or sometimes infections like tuberculosis, can cause inflammation. When these joints inflame and they start rubbing up against each other over a prolonged period of time, we can eventually get what's called ankylosing spondylitis, where they actually begin to fuse together. So we lose that motion, they actually begin to fuse together, and the bones will be stuck to one another, okay? So those are all of our spondy-related conditions. DDD and DJD, degenerative disc disease and degenerative joint disease, kind of a catch-all term for anything now relating to the discs, okay? Or again, the joints between them all. Nerve compression and radiculopathy, that's for instance, sciatica, anything with the brachial plexus. I woke up and my hands and fingers were asleep, okay? That's when we get something's pushing on these spinal nerves, okay, especially up here in the cervical spine, but sometimes down here in the lumbar spine as well. That could be because there's bone pushing on it, inflammation, if there's a disc bulge and it's pushing on it. Anything that pushes on this will then become radiculopathy, where it travels, and that's where we get that numbness and tingling feeling. Whiplash, common motor vehicle accident, sudden stretching of the cervical muscles, and then fractures, okay? So spondy-related fractures, but also we can get fractures, for instance, if we fall and land on our back, we can break the spinous processes. The elderly and sometimes women are subjected to osteoporosis or poor bone mineral density. They step off the curve kind of funny, they take a load, and we can fracture these vertebral bodies as well. And also common with firefighting and other related professions where we're carrying a lot of weight, just stress fractures in general, okay? Repetitive motions, a lot of weight-bearing loading, we can get a lot of stress fractures as well, okay? These are some of the common injuries that you're gonna see again with the cervical spine and the lumbar spine in particular. Here we have just, again, another image, okay, bulges into the spinal canal. Along with here we have a large herniation, okay? You can also see a little bit of more degradation, more bulges along the other vertebral bodies. We generally get posterior or lateral bulges or herniations. It is where we are weaker because the front part of the vertebral body is a little bit bigger than the back part of it, but also because there's a lot of ligaments that run through the front side of the spine compared to the back. So they usually come out the back or come out the sides. Okay, so we're gonna go over the healing process and the medical process. Just really quick, and there's a lot that goes on, but we're just going to talk about a few of these steps in case you get hurt and then what happens. So we get hurt and we bend over to pick something up and I hurt my back. The first process we have is called the inflammatory response or inflammation phase. Okay? This occurs immediately. So right when you get hurt, for instance, you sprain an ankle and it swells up, that's what we're talking about. Everything inflames, it starts to swell up, the body sends a bunch of fluid to the area and says, hey, there's something wrong. We have an injury and we're going to try and keep ourselves from getting more injured. People think of inflammation as being a bad thing. We always hear we don't want inflammation, inflammation's bad. Chronic inflammation is bad. You want acute inflammation. You want your body to have this inflammatory response because, again, it's a defense mechanism. Same thing with stress. Acute stress is good if a bear is chasing you, but chronic stress is bad if we just hang on to it every single day, right? So inflammation is the same thing. It occurs immediately, can last up to about a week. That's what we're looking at trying to modulate. But again, it's the body's defense mechanism. We're going to swell up, the muscles will tighten up, they'll splint, and it's the body's way of saying, don't move anymore. We don't want to create more of an injury. So again, inflammation is good. Chronic inflammation is what we're going to try and kind of nip in the bud. The next phase is proliferation, 1 week up to 21 days. Then remodeling or maturation is 21 days up to 2 years. This is where we are sending cells to the area, cleaning up anything that's dead, we don't need anymore, laying our initial foundation, and then we go into the remodeling or maturation where we now lay our long-term permanent structures, our scar tissue, things like that again. So this process can take a very long time. Medical processes, okay? What are you going to do if you get hurt? This is what your body's doing. This is what you're going to do, okay? You get hurt. You're going to go in. You see your doctor. They might send you for some imaging, MRI, CT scans, X-rays, okay? MRIs are going to look at soft tissue structures. It's going to be your ligaments, your muscles, your discs, if there's a concern for discs. X-rays, obviously we're going to look at the bones. We're going to look at, see if there's a fracture, or we can look to see if the bones are closer than they're supposed to be, which might tell us we need an MRI to look at a disc. From there, you might get sent to pain management, injections, medication, things like that, physical therapy for treatment, and there are different surgeries, generally now a little bit less invasive than they used to be, but there are fusions, there's laminectomies where they go in and scrape away and clean out some of the bone that's in there. They can do disc replacements and discectomies where they take the disc out. A lot of different surgical options, like I said, very generally minimally invasive nowadays. So pain, when we're going to talk about pain in this case, this is how the body understands pain. Now, this isn't a catch-all. This isn't the only way, but we're going to talk about some of our modalities and our treatments, and this is generally how pain is perceived in the body. So it's called the gate theory. There are two different pathways, a non-nociceptive and a nociceptive, so pain, that's what I'm looking for. Pain signals and non-pain signals. Okay, our A beta fibers are non-nociceptive. They are larger fibers, okay, compared to our C fibers, which are nociceptive, which are pain fibers, are smaller fibers. So we get hurt. Something happens, we get hurt, we bend over, we hurt our back, right? We have pain, the C fibers go and they tell our body, up to our spinal cord, up to our brain, hey, we're in pain. Something happened, we're in pain. Well, if I use some kind of modality or treatment, for instance, electrical stimulation, ice, heat, things like that, okay, they are going to stimulate our A beta fibers, our non-nociceptive. So again, our larger fibers. Because they're larger, they get priority. So the signal comes, the pain signal and the A beta fiber, or the treatment signal come, and they meet in the spinal cord, and it says, nope, we're going to listen to the treatment or the A beta fiber. That takes priority. That goes to the brain, and it says, nope, we're fine. There's no pain. Okay, so in essence, it closes the gate. Now the body isn't picking up the pain signal; it's only picking up the treatment signal, and that tells us we're not in pain anymore. So some of our modalities, okay, very, very common. First off, heat and ice. Everybody has access to heat and ice. And we're talking ice packs. We're talking just, ice in a bag of frozen peas, things like that, okay? Even cold water, submerging in cold water. Then we're talking about heat. That's your hot packs. That's your jacuzzis, your saunas, a warm shower, okay? Anything like that, that's our heat. Ice and heat will cause a mechanical change in the deeper structures if it's cold enough and warm enough. Okay, so we're going to get vasodilation with heat, we're going to get vasoconstriction with ice. So it'll create an actual mechanical change. That's important when we are dealing with our injuries. So you bend over, you hurt your back. People usually think to put heat on. We prefer heat. Heat is more comfortable than ice, generally speaking. The first 24 to 48 hours of an acute injury, ice is actually recommended. So again, bend over to go pick something up, pull your back, throw ice on it the first 24 to 48 hours. After that, you can heat to your heart's desire, okay? Again, bathtubs, jacuzzis, warm showers, hot packs, things like that. All of that's going to help to relax the muscles. All of that's going to help to create vasodilation, help bring new nutrients to the area, help push some stuff out. Ice is going to cause that vasoconstriction. It's going to help with that inflammatory response that we're talking about. Again, we want that inflammatory response to happen, which it still will in the first 24 to 48 hours, even with ice on. We don't want it to get out of hand. So icing right away is going to be important. So that way we don't get this lingering inflammation that just hangs around in the area. So ice is going to help with that. So ice first 24 to 48 hours for an acute injury, and then you can heat it as much as you'd like. Biofreeze and icy hot are popular as well. The only difference with those, and take the lotion, you're going to rub it on. It creates only effects at the superficial level. It doesn't create any mechanical changes at the deeper level the way ice and heat can, because they can get colder and warmer and they affect the deeper structures. Biofreeze and icy hot in this case, just superficial, but it'll still tell our body, hey, something feels good, and it'll take those A beta fiber pathways and it'll say, hey, we're not in pain, we're comfortable. NSAIDs and pain relievers, non-steroidal anti-inflammatories, okay, and pain relievers, they do exactly what they say. In this case, NSAIDs, you can start taking those, especially for chronic inflammation. A little bit of taking an Aleve or an Naproxen or something like that will help knock down any chronic inflammation, and pain relievers will do exactly that, just help with some of the pain modulation. A TENS unit, okay, a lot of people have TENS units, little battery-powered units that come with pads. You stick them on, they cause little contractions. Okay, a TENS unit is great, especially for tight muscles, the low back, the neck, things like that. You can stick them on, throw some heat on there as well, and then that way it'll contract, you'll get some heat, and everything will start to relax. Research shows that after taking a TENS unit off, about 20 to 40 minutes afterwards, the benefits are now gone. So what does that mean? Well, TENS units are still great, still use them. It's just a particular way to use them. If you're going to use a TENS unit, let's say you woke up, your neck is stiff, okay? Put the TENS unit on, put the hot pack on, and rather than just sitting there and it feels good and not doing anything, okay, if your neck was tight and you couldn't turn it, put the TENS unit on, put the hot pack on, and then now that you're in a little bit more of a relaxed state, pain-free state, start to go through further ranges of motion now that you're not in pain. That way when you take it off, the benefits of TENS will be gone, but the new relearned pain-free motion will stay. So instead of, again, just sticking them on or sticking them on your back and sitting there, try and go through some motions now that you're not in pain, so you'll get more pain-free motion once you take it off. A foam roller, okay? You don't have to get anything fancy, okay? There's ones with knobs and they vibrate and they heat up all the stuff, okay? $15, get it on Amazon or Target, something along those lines. Okay, a foam roller works like, you know, rolling pin on dough. You're just gonna roll out the fascia, you're gonna roll out the muscles, okay? A foam roller is great to use prior to stretching. So I always recommend that you heat first, get everything nice and loose and relaxed. Then you can foam roll it out. Again, if it's like our dough to our pizza, we're gonna foam roll it out. But now we need to stretch it into our pizza shape, right? So heat, foam roll, and then stretch. That's the order it should go in. Theraguns, a lot of people have Theraguns, okay? Like this. They used to look like Ryobis with a ball at the end of it, okay? Same thing. There's a lot of different brands that you can buy from online. Theraguns are great, same thing, for percussion on the muscles, especially large muscles, the traps in the back, the low back, quads, hamstrings, anything like that. You just need to be very careful on some of the smaller areas, bicep tendons. You don't want to do it really close to your skull, along your bones, anything like that. It is a micro trauma. It's a repetitive micro trauma, so it will cause a little bit of inflammation. So in smaller areas, you need to be careful, but it's a great alternative, especially if you can get someone to kind of do it for you. It's a little awkward if you do it yourself in some areas, but Theraguns are a great option. Similar to a massage, I usually don't have to convince people into a massage, okay? Everybody likes massages for the most part. In comparison, acupuncture, okay? Get a lot of eye rolls with that. Research show acupuncture is actually very beneficial for pain regulation. The caveat is it depends on the person. when it works well. But for some people, for whatever reason, the different pain pathways and things like that, everybody's different, it can work for one person and work really well. If you go to do it and it doesn't work for you, then it's probably not for you. But I always put it up as just an option. The studies show that it is beneficial. You just have to give it a shot and see if it's for you. Chiropractic care, okay? We usually hear that physical therapists and chiropractors are like cats and dogs, okay? I love chiropractors. They do great work. You just need to find a good one, just like anything else. Good physical therapists, good doctors, okay? A good chiropractor is going to go in. You're going to get your back cracked. And they're going to give you some exercises and stretching and stuff like that to follow up with getting a manipulation. Why is that important? If something got you out of alignment, the underlying mechanism, just because we manipulate you and put you back into alignment, we need to do something to keep you there. Whether that's strengthening, whether that's stretching, whether that's some kind of modification. Okay? Chiropractors and physical therapists do what's called a grade 5 manipulation or a thrust, a high velocity, sudden joint manipulation. Okay, that's where we get the popping and the cracking sounds. This is going to be different for everybody. You kind of need to know if you've got any underlying issues. Because like we were saying before, our larger low back vertebral bodies and discs mean that there's a lot more room, there's a lot more space in comparison to our smaller cervical areas, not as much space. Less room for error, greater room for error, greater margin of error, okay? A disc bulge, this little red thing, that's not what it really looks like, but that's our little disc bulge, okay? A little disc bulge, which are graded generally in millimeters, okay? You 2 to 3 is small, 3 to 5 is moderate, 5 to 7 is pretty severe. Anything greater than 7, you're usually looking at surgical interventions. Is a little disc bulge you can kind of get away with here. You go in and you get your back cracked, and because it's very forceful and sudden, there's really no turning back from it. We just do the manipulation and we get what we get kind of thing. If a small disc bulge gets a little bit bigger, you probably won't notice. Not to say that it will get bigger, but if it does, okay, you may not notice. Versus the cervical spine, if you have a disc bulge and we do a manipulation at the cervical spine, a little, slightly larger disc bulge can be very noticeable. Again, so smaller margin of error, larger margin of error. All that means is you need to know if you've got any injuries, any underlying conditions, and talk with your chiropractor beforehand just to be careful. But again, just be careful at the cervical spine in particular. Traction and inversion, okay? Traction will put you on a table, we'll hook you up at your ribs and at your hips, and we will pull you apart. We'll do the same thing for the cervical spine, and we'll hook you up right here at the base of the skull, and we will pull. What we're trying to do, okay, is pull the vertebral bodies apart. And if we have a disc bulge or a disc herniation, we want that fluid to go back to the center of the disc where it's supposed to be, okay, and pull you apart, let it go back, and then put you back together. Research shows that that's not really what happens, the way that we used to think that that's how it worked. It can work if it's a newer injury. So the body has what's called plasticity and elasticity, the ability to learn new motions, learn new ranges, learn new habits, things like that. And elasticity, the ability to come back to those as well, okay? So if you get a disc bulge and the jelly from the jelly donut is starting to squish out the side, and you just got it last week and you went to the doctor and the doctor said we're going to send you to physical therapy, and we decided that we're going to do traction, okay? It's a very new injury. That plasticity, the body has the ability to, again, learn new ranges. That elasticity, it can still go back. So in essence, if it's new, if we squish our jelly donut, it can go back to the center. In comparison, if you get a disc bulge and you spend years not doing anything about it, that plasticity, that body, that intervertebral disc and the vertebral body have now learned a new range. They have stretched out. Their likelihood of returning back to their original position is very, very low. Same study, same research though shows that traction is still the gold standard for pain modulation, okay, and pain management. So even if we can't fix the disc, we can still address a lot of the pain that comes from it still. So traction's still very, very important and used often. If you can't get to a traction table, your PT office, your chiropractor's office, okay, there's also inversion. These are your inversion tables, okay? You'll see them a lot. People buy them, they set them up, and they sit in their back room and they throw clothes on them, okay? So you usually find them used on Craigslist for pretty cheap. But you are, in essence, creating the same thing by hooking up your ankles, hanging upside down, and gravity is going to be what pulls you down based off of your upper body weight, okay? That will then space out the discs, or space out the vertebral bodies, and create some relief in that sense. You can also do the same thing hanging from a pull-up bar. You can sit in a chair and press down on the armrest if you've been sitting in a chair for a long time. They're very short-term options, but they can provide a little bit of relief. Inversion, you just need to be careful, okay? When you are tractioning the body, you're also tractioning all the other joints, your ankle, your knees, your hips, so you need to be careful if there's any replacements or ligamentous injuries. Also, if there's a problem being inverted, if you have GERD, ocular degeneration, blood pressure issues, anything like that, then inversion isn't recommended. Insoles, okay, so we look at the kinetic chain. A good pair of insoles, especially in work boots when you're in them for a long period of time, can make a huge difference. So if you put a good pair of inserts into your shoes, that will affect your foot and your ankle, which will then affect your knee, which will then affect your hip, which will affect your low back, okay? So always look at your inserts in your shoes, put them in your walking shoes, your work boots, anything like that, and replace them often. Lastly is hydration, like we said, okay, the intervertebral discs are about 60 to 80% water. The more we can stay hydrated, the more plump they will stay, okay? So always make sure you're hydrating, getting your electrolytes. That will help keep these plump, which will help keep these spaces nice and open, which will keep us from having any associated pain from that. All right, so now we're going to talk about injury prevention. So injury prevention has three components. We're going to talk about stretching, we're talk about strengthening, and we're going to talk about activity modifications. So for stretching, we're going to look at global and local mobility, okay? So do we have our full range of motion in our ankles, in our shoulders, everywhere else? Also, do we have our range of motion just in our neck, just in our low back, okay? Functional range of motion means, do we have our range of motion to do our daily activities, okay? Some people, it's hard to get their arms overhead. Some people are extremely hypermobile, okay? So do we have our range of motion to do our functional activities? Tight or overly stretched muscles are weak muscles, okay? So what does that mean? If my pecs are super, super, super tight, okay, then they're not at an optimal length. They're too contracted, okay? And that's gonna have an influence on other parts of my body. Just as much as if I'm very, very hypermobile or overly stretched, then it's not at an optimal length to then create a contraction for strengthening, okay? So again, we're gonna talk about the optimal length that muscles should be at when it comes to stretching and strengthening. So tight muscles are weak muscles, overly stretched muscles are also weak muscles. Strengthening. Talk about two different fiber types. Our anti-gravity or postural muscles are our type 1, and then we're going to talk about type 2, which are more of our power muscles. Global and local stability. So do we have our balance? Do we have our ability to correct ourselves in space? But also, do we have local stability? Is our shoulder girdle nice and tight so our shoulders are strong? Is our core nice and tight? Do we have strength there for stability, okay? Lastly, we're going to talk about foundational functional exercises, job-related exercises, exercises that are going to work our muscle fiber type the best way that they can to be optimal. Anything for, again, our day-to-day exercises that are going to apply to our day-to-day activities. And lastly, activity modifications or our daily activities. It's our meat and potatoes. What can we change now? What can we change in our daily activities to help with our posture, to help with our mechanics, things like that? It's important to focus on the entire kinetic chain. Again, just like talking about the foot has an influence on the hips, has an influence on the back. Our arms are going to have an influence on our shoulder girdle, has an influence on our neck. Okay? Everything has an influence on the entire body, and in this case, the spine. Everything gets kind of transversed through the spine, our center of mass, our low back, our neck, things like that. So we're going to look at the whole kinetic chain. So stretching, first and foremost, okay, when and how to stretch. We hear a lot about, dynamic stretching versus static stretching. Those are our two most common types. Dynamic stretching is our stretching with movement. So it's our arm circles, our trunk twist, our high knees, our butt kickers, things like that. We're stretching, we're warming up as we're moving. Compared to static stretching, which is just our stretch and hold, okay? Our reaching down to the floor, holding for 30 seconds. That's our static stretching. You want to do dynamic stretching prior to activity. If you're going to exercise at the gym, you're going to play a sport, things like that. You want to warm up and get all of the fluids moving, that kind of stuff. In comparison to static stretching is going to be our cool down after we've warmed up, after we've worked out. Again, if we've heated and foam rolled, then we can do our static stretching. That's where we're trying to increase our range of motion. Dynamic stretching is going to be a little bit more, we're just warming up. Static stretching is, can I try and get more range of motion after stretching for a certain period of time? Our static stretching is what we're going to really talk about. We want to look at 30 to 60 seconds for holding certain positions. So again, we're reaching our toes, trying to stretch your hamstrings. You want to hold that for about 30 to 60 seconds. You're going to do that multiple times. There are different ways to warm up. Again, dynamic warm up where we're moving, but I always also recommend heating. Our fluids in the body are a lot like motor oil in an engine, okay? When you first start your car, it's cold, it's thick, it doesn't want to move very well, it's not very viscous. As it begins to warm up, it thins out, then it gets through the system, starts bathing everything, right? Our fluids, in particular our synovial fluid, which makes up a lot of our joints, is the same way. You feel it in cold mornings, when it's stormy out. A lot of people who've had surgery say, my joints hurts because the nerves are now really sensitive to atmospheric pressure, things like that. Throwing on a hot pack will kind of kickstart that system. So you have a long drive into the station, for some of you, very long drives into the station, okay? And you woke up again, your neck's kind of sore, your back's kind of sore, your shoulder's sore. Throw a hot pack on, 20 minutes, same with ice, 20 minutes on, 20 minutes off. You can do that multiple times, but that will start to warm up the fluids, thin everything out. They'll again become more viscous, and it'll start to bathe the joints, which will help with once we start to get moving, then we're already warm, we're already kind of a step ahead. So important to warm up prior to stretching. So when it comes to stretching the cervical spine, we want to look at our range of motion for just, again, that local range of motion of just the spine. Can we turn and look over each shoulder? Can we bring our chin down to our chest? Can we look all the way up? Can we look up and over the shoulders, okay? That's gonna tell us our musculature right in our neck. So if I can't look up and over the shoulder and it's really tight, we're gonna be talking about our scalenes on the anterior side, our sternocleidomastoids, okay? So a nice easy stretch that way. If I can't turn down and look towards my armpit, we're talking about our upper traps here in the back, okay? So just local stretching right at the joint. Same thing for the low back. Can I turn all the way? Can I bend down and get close to touching my toes? Can I arch back? That's your local mobility that we're going to look at. But in the cervical spine, we're also going to look at the chest and the shoulders. So again, that shoulder girdle has an influence on the neck as well because of how many muscles begin to attach to it. But also, if my chest is tight, we have a tendency to sit in chairs, sit on our phones, sit on our laptops. We have this forward head posture, very rounded shoulders, okay? Then my chest starts to tighten up, okay? Our pecs right here in the front start to tighten up. Again, tight muscles or weak muscles. Well, if I'm rounded here, then everything in the back, my rhomboids, my middle traps, things like that in the back are now very stretched out. Now they're very weak, okay? Again, overly stretched and tight, weak muscles. So we want to talk about opening up the chest. That's standing in a doorway, okay? They can be both arms or one arm. That is laying on a foam roller, okay? So it's up and down your spine and opening up the chest, okay? If we can really open that up, that'll keep us from being here, having that forward head posture, having an influence on the cervical spine. That'll open us up. That way we can bring the head back a little bit more, okay? It also means our rounded shoulders. We got to work on bringing the arms back, the shoulders back, okay? So when we talk about stretching the cervical spine, we want to talk about the posterior muscles like the traps, the levator scapulae, okay? And also the anterior, the scalenes. Then we want to look at the chest muscles, the pecs, okay? And we want to look at the shoulder and the back side as well. If that means, again, internal rotation, external rotation, that kind of stuff. If we're here, we want to open up through here. The thoracic spine, okay? You think there's not a lot of mobility there because of the rib cage attachment, so it's very stable, but where something's stable, we need to work on keeping it mobile. Just as much as something that's mobile, we're going to need to work on keeping it stable. Mobilization of thoracic spine can be done a few different ways, okay? I love using a foam roller. Now you're going to take that foam roller, and this is your spine. You're going to have it this way, so perpendicular, and you can just roll up and down on the cervical or on the thoracic spine. So then that way you can mobilize each joint, okay? You can also do large influences like the lat has a big influence on the cervical spine, and anything where we are closing and opening. So thread the needle on all fours. We reach through and then we pull open. You can lay on your side and do open book, things like that. I also really like the Zotz press for some of our weightlifters out there. Put a PVC pipe or a barbell on your back. Okay, we're here behind the neck. We press up and over, and then we return back down. That's really going to try and pull our shoulder blades together. We need good thoracic mobility for that. And then we're talking about overhead. So a lot of times people will say, man, I can't get my arms up over my head. I must have bad shoulder mobility. It's not necessarily the case. If I can get my arms up to 180 degrees, but I'm rounded and my thoracic spine doesn't have mobility, then it looks like this. When in actuality, if I then mobilize my thoracic spine, I can get to here. Why does that matter? Well, if I don't have good thoracic mobility or shoulder mobility, and I can't reach for something up above me, I compensate through the low back. Okay, so it's going to be really important, again, working on our shoulder mobility, but thinking about the thoracic spine as well, as that maybe that's the actual problem, not just the shoulders. Okay, so mobilizing the thoracic spine is going to be important. Lastly, the lumbar spine. When we talk about stretching the lumbar spine, there's a lot of different aspects. We're going to look at force couplets here, but we're talking about the hips, again, the pelvic girdle. So that means our hip flexors. Our hip flexors attach right through here on the front side of the ilium and come through and attach on our femurs, okay? And they also attach through the transverse processes in the lumbar spine. So if our hip flexors are tight, they will pull on our lumbar spine as well. A great way to release your hip flexors. You see a lot of people, they buy the little blue plastic guy that looks like a little U and it pushes in. If you don't have something like that, take a kettlebell, take the handle, angle it right along your inguinal ligament, right through here of the hip, okay? And you're gonna lay on it. Yeah, you're gonna put your knee down, put your elbow down, lay on it, relax, breathe, okay? It's not super comfortable. And then as you get comfortable, just kind of lean into it a little bit more. Okay, the iliopsoas, which is our major hip flexor, is deep to our rectus abdominis or transverse abdominis. It's a very deep muscle. If you put your hand on your iliac crest with the little bone that you feel sticking out, and you push in and you bear down, you can feel it pushing out against you. But it's a very deep muscle, so you have to be able to relax into that kettlebell and lean into it to get that deep release. So the hip flexors are going to have an influence. The glutes, okay, we talk about our piriformis here is a hip internal external rotator. Our glutes, okay, our glute med, our glute max, okay, we're going to want to stretch those out as well. And our hamstrings. Hamstring tightness is the #1 indicator for future low back problems, okay? Our hamstrings are tight. They're going to pull, again, on our pelvic girdle, and they're going to have an influence on the low back. So hamstrings, foam rolling hamstring. Again, your traditional sit and reach, taking a strap. If you can't reach your toe, take a strap around your foot, like a dog leash, something along those lines, and just kind of pull yourself towards it. Because it's a knee flexor, we have a tendency to sit in chairs a lot. So that shortens, that tightens up. And then once we are in a standing position, okay, because it's tight, it's going to pull again on the pelvic girdle. The abdominals on the front side, if our abdominals are very, very tight, okay, again, that's going to pull on the pelvic girdle. So that's like our cobra stretch, laying on our stomach, pressing up our cobra stretch. The posterior muscles, that is our, you hear a lot of, quadratus lumborum, our QL, our erector spinae. We have a lot of little muscles that run the length of the spine, along with larger ones like our lats have come in. They insert down here on the iliac crest again, but a lot of smaller ones. Our QL is a lateral bender. Okay, so if one side is really, really tight, you want to bend to the other side. Okay, so our lateral flexion. Anything, if we have a tendency to be very hyperextensive, so again, bending forward at the trunk, that's going to help stretch out our posterior muscles. And lastly, you want to look at the fascia. So there's two large fascias we're going to talk about. We have our thoracolumbar fascia back here in the back, and we also have our IT band, which runs along the femur. That affects, again, the pelvic girdle, so you want to roll that out. Fascia is supposed to be tight. There's nothing wrong with it being tight, but if it's too tight, again, it'll pull on the femur, it'll twist our hips, it'll twist our pelvic girdle. Same thing up here. We also have fascia in the front, all around. It's like the casing of a sausage. If it's really, really, really tight and it's squishing down on everything, we want to roll that out, massage that out, loosen it up, so that way the muscles have room to move around. So you want to work on the fascia as well. This is our force couplet. This is very large force couplet. There's other ones in the body, but this one has an influence, again, the pelvic girdle and the low back. So our pelvic girdle can move a few different ways. We have an anterior tilt, or what's going to be called a sway back syndrome. Posterior, where we tilt back, which is our flat back syndrome, and then we technically have lateral tilts as well. But in particular, these two tilts have, again, an influence on the low back. If my erector spinae, or my back muscles, are really, really tight, and my hip flexors and my quads are really tight, we're going to get that anterior pelvic tilt. That's going to cause a lot of hyperextension in the low back, which is going to cause everything to, again, close off. On the reverse, if I have a posterior pelvic tilt, my hamstrings and my glutes are very tight and my core is very tight, or my abdominals are very tight. You see that a lot when people who sit for long periods of time. Well, both of these, again, are going to have an influence on the low back, and it's going to change that natural lordotic curve we have, either straightening it out or really hyperextending it. So if my low back, my erector spinae muscles are really tight and my hip flexors are really tight, well then what I want to do is I want to roll those out or stretch those out, okay? So we're getting the hip flexors and the quads, the back muscles, and I want to strengthen the other two. I want to strengthen my glutes and hamstrings. I want to strengthen my rectus abdominis. So that way I go from this position and I straighten back out. So I stretch the other two and then I strengthen the other two. Reverse, the posterior tilt, if my abdominals are very tight and my hamstrings and my glutes are very tight and I have that posterior tilt, then I want to work on stretching out the front, stretching out the back, and strengthening the hip flexors and strengthening my low back muscle. So again, I go from being in this straight position back to my natural curve. So the force couplets, again, very important when we look at how they influence the low back. Strengthening. So there's a few different aspects to strengthening. First of all, we have our axio-appendicular attachments. So what does that mean? Our axio-appendicular are muscles that attach from our trunk to our appendages, okay? Our axial skeleton to our appendicular skeleton. Again, important for the pelvic girdle and for the shoulder girdle. We're talking about large muscles for the shoulder blade that attach from the shoulder blade to the spine. We have like our rhomboids and our traps. And again, same thing for our hip flexors that attach from the trunk to our femur, okay? So it's not just your small local, wrist extensors or flexors or our calves, things like that. It's our larger, our pec attaches to our humerus, okay? So how those have an influence. Our type 1 and type 2 muscle fibers. So we're going to get a little involved here. Type 1 muscle fibers are our anti-gravity or our postural muscles. They are endurance muscles. They're meant to work for a really long period of time. For instance, our soleus, one of our calf muscles. Our low back muscles, our erector spinae muscles, okay? Those help keep us upright. As bipedal creatures, we need to stay upright in the world, okay? Our posterior neck muscles, they don't produce a lot of force or power, but rather they continuously work throughout the day, which is why we don't slowly bend over and get tired throughout the day. We stay upright because these muscles are meant to work for a really long period of time. It's going to be important when we talk about how you work them. What is the best way, the most optimal way to work them? In comparison, our type 2 muscles are more of our power muscles. Our quads are big type 2 muscles. Our biceps are type 2 muscles. Now, all muscle groups have a little bit of both, but it's going to be a matter if there's more type 2 fibers or more type 1 fibers. So again, in the case of the quad, a lot of type 2, we have a lot of power production in comparison to, again, the soleus or the low back muscles, more type 1. So they're going to last longer in comparison to type 2, a lot of power, but they fatigue much quicker. So when we look at the cervical and thoracic spine, there's not a lot of strengthening that we do for the cervical spine per se, very localized. Again, they're more postural muscles. We don't really need to work them. They're very small muscles in comparison to working our scapular stabilizers to prevent dyskinesis. So dyskinesis is poor movement patterns or incorrect movement patterns. So a lot of times our shoulder blades don't move properly because we're really tight or we're really weak. So our scapular stabilizers are going to have an influence on our cervical spine. So that's going to be looking at a lot of retraction, okay? Bringing the shoulder blades together and bringing the shoulder blades down, that depression. So our rhomboids and our low trap muscles, okay? We have a tendency to have overdeveloped upper traps, okay? So our big trap muscles up here that we're usually massaging, we usually have a tendency, they're very tight, they're usually overdeveloped. So you usually want to stretch those out more than anything. They get worked just by carrying things throughout our day-to-day life. So we don't always have to go, and we can do lots of shrugs and they get bigger and it's great, but is the fact that we don't have to work them out the way we need to work some of our smaller scapular stabilizers. So again, talking our shoulder external rotators, okay, so our infraspinatus, we're talking rows, bent over rows, therabands, things where we're bringing the shoulder blades together, some pull downs for our lats and our lower traps. So you want to look at the scapular stabilizers as what we're really trying to work. Now, forward head posture, again, we have a tendency to be this way. We can strengthen the cervical spine. Again, we're mostly going to stretch it, but in the back, we have a tendency to be very weak. So you can work on chin tucks, you can work on pushing back, isometrics where you push against your hand, hold it for about 10 seconds. Those will work the muscles as well. If we feel like I'm in a forward head posture and I want to work on coming back, then we want to work on some strengthening for the posterior muscles. For the lumbar spine, we're going to look at our hip alignment first and foremost. So again, are we straight? A lot of times, again, we might have a slight lateral tilt, a little leg length discrepancy, one leg shorter than the other kind of thing. But if I'm not aligned, if I don't have a good foundation, then I don't want to start building on that, right? So we want to look at our alignment. We want to look and see, again, do I have an anterior tilt? Do I have a posterior tilt? Do I have a lateral tilt? Let's fix that first. So if we need to stretch out one side, if we need to kind of start, again, stretching out our hamstrings, anything like that. And then once we're in good alignment, we could talk about strengthening. So functional movements for the low back are going to be important. Again, if I just do 50 sit-ups, sure, it's going to work our rectus abdominis a lot, but how often do we do that just motion repetitive over and over again? What you want to do is unilaterals and diagonals, because more often than not, those are what we're doing in our day-to-day life. We don't just stand and move and pick something up and do these perfect planar movements. We're usually reaching, we're usually kind of staggered stance, things like that. So we're talking our unilaterals, our heavy farmer carries, okay? We put something heavy on our, hose bundle on our shoulder and walk, things like that. You can do single leg RDLs, deadlifts, that work on our balance. We want to do single leg stuff. We want to do staggered stance, our lunges, our lunge and twist, things like that. And diagonals, again, we don't just always perfectly move things. We kind of reach for things. We reach down for things. We're moving around. We're off center. We're off balance. So you want to work on that. You can use, wood chops, things like that. With a cable machine, big cable machine, you can usually get some diagonals in there. And again, working on your balance in particular. Putting on your SCBA when you're working out will displace your weight. It will change the way that you move. So consider working out in your gear or something similar, weighted vest, things like that. But if I put a big heavy tank on my backside, well, now I'm off center a little bit. I gotta correct that. So consider working out in your gear. When we look at strengthening our lumbar spine, we want to focus on time domains. So that's that type 1 muscle fiber. It's not just doing, again, 50 sit-ups. Can you hold a plank for 30 seconds? Can you hold it for a minute? Okay? Can you hold a side plank? A Superman position where you're on your stomach and you're lifting your arms up, okay? And putting us in that extended position. Really working the backside of the muscles. The hollow position on your back where we're in a little, look like a banana, okay? So those are going to be really important because that's the best way to work these type 1 fibers, these postural fibers, okay, is doing it for time. Then once you start to get to a point, I can hold a plank for 5 minutes, okay, well now can you hold a plank while correcting your posture or keeping yourself aligned? So if you stay in a plank position and then you reach out with the hand, okay, or you come up into a high plank and then back down and try to do that anti-rotation, try and keep your core really, really tight. Those are going to be the best way to work out these muscles, is to think about time domains rather than repetitions or weight. In comparison, again, to some of our scapular stabilizers, our, rhomboids, that's going to be, although there's a time domain to that as well because it's an anti-postural muscle, but a little bit more, you can do some heavy weighted rows, things like that. The lumbar spine for our low back in particular is going to be a lot more time domain based. So again, here's a lot of the muscles that we're talking about that we're working. So through here, okay, we have our upper trap, middle trap, lower trap, our rhomboids in the back, again, all affecting the shoulder blades, all attaching to our thoracic and cervical spine. We also have our external rotators of the shoulder. On the front side, we have our large pecs, pec major and pec minor underneath it. Our deltoids of the shoulder, our lat, see, coming right through here, thoracolumbar fascia, that's our fascia that we want to roll out. Our lat that comes through, okay, again, internal rotator has an influence on the shoulder, but it comes all the way down, attaches to the hip and the low back. On the front side, okay, we have our rectus abdominis, our transverse abdominals, internal and external obliques, again, are ones where we're rotating. All of these are different muscles that we're going to try and aim on working, okay, and how they're going to have that influence, again, on the spine somewhere in there. Our really, really small occipital or semispinalis muscles are also ones that people have a tendency to feel like if you get a lot of headaches, really deep right at the base of the occipital bone, the base of the skull, that's great if you take like two racket balls and put them together and you can roll on those. You can get right up in there to release those, but that's where a lot of like tension headaches come from as well. Just a fun little one in there. Okay, so again, here's just a few examples. So here's our Zotz press, behind the neck, pressing up and over, okay? You can do it seated as well. You don't necessarily have to do it in a low squat. Our high plank, so again, we can go from high plank to low plank. We can do plank reaches, okay? We can do side planks. Our single leg RDL. Here's a great way, again, to open up that chest on the foam roller. Our trap stretch, okay? We're here. We can also look down. We can look up and over to the corner. And a heavy suitcase carrier, single arm farmer's carry. Again, just examples. There's a lot of different exercises you can do, but we're talking type 1 anti-postural or anti-gravity postural muscles versus our, type 2 muscles or versus stretching, okay, again, unilaterals. You can turn those into diagonals, a lot of different ways that we're going to try and manipulate these exercises to be more functional. All right, last thing, what can we just do right now today to help our spine? So I have some activity modifications. Our posture is huge. So we have different postures when it comes to standing, sleeping, and sitting, which I'll go over here. Our posture, we're going to, again, try and keep those natural curves in our body. So when we come out of a good posture, we are influencing those curves. And then now we are having an effect on the load distribution, our shock absorption, things that are going to start rubbing that shouldn't be rubbing. It just throws everything out of whack if we don't have good posture. Okay, so we're going to go over that. When we talk about driving, all right, if that means we're driving into work, if that means just our day-to-day driving, we're going on a strike team up to the Oregon border and we're in our type 3 for a long period of time with great suspension, okay, if it means our trips to the river, whatever it is, okay, the first thing, wallet and phone, especially for some of you guys that carry like a big, wallet in your back pocket and you sit in your chair, okay, that will pop up one side of the hip, which will close off one side of the spine and open up the other side, okay? So we always recommend wallets and phones out from the back pocket, either the front pocket or, in your center console or something along those lines. Adjust your seat. So for driving, okay, we can't change what side of the car we're on, right? We can't change that we're gonna put our right foot forward. Unless you're cool and you got a stick shift and you get to use both. But we have to put our right foot forward, which means we have a twist in our hips, okay? And if we're too far away, we're gonna have to reach. So again, that's causing a twist and closing off one side of our spine. Bring the seat a little bit closer, okay? So that way we're not sliding down, we're not reaching, okay? And take breaks. So if you have a really long drive, if you're driving for an hour, I know it makes the trip longer, but get out and stretch a little bit. It will give your muscles a break from being in the same position. And we have a tendency to get back in the car in the proper position. So maybe over an hour we've started to slide down, we've shifted a little bit and we're not in a good position anymore. We have a tendency to get back in the car in the proper position. So it'll kind of break up, rather than sitting in the wrong position for 6-hour drive, it'll kind of break it up and it'll realign you and reset you so you're in a better posture. So for every hour, get out for about 5 minutes or so, 5-10 minutes, get out, stretch, take a break and get back in. Also, there's bolsters that you can buy for your regular chair or for your car chair or your car seat, and you can get them off Amazon, and they strap around the back side of the chair and they keep a nice natural curve in the low back. Okay, it works as a tactile reminder, so you'll sit up against it and it will remind you to stay in that position, but also because they're a hard foam bolster, you can't start to slouch and push against it. Because it's hard, it'll push back against you. So again, it's a good tactile reminder. But if you don't want to get a bolster or you forgot it at home or something like that, an alternative is to take a jacket, roll it up nice and tight, and stick it back behind your low back. At least it's a very quick alternative, or if you're in a meeting or in a lecture or something and you just like, man, my back's starting to hurt, and you've got a jacket, roll it up and stick it behind you, and that'll help keep you in a nice, good posture. Our standing posture. We have our poor flat back, or that posterior pelvic tilt forward head posture. Our nice balanced upright posture, which is what we are always trying to maintain. Our shoulders are stacked over our hips, over our feet. And then we also have a sway back, or that anterior tilt where we're through here, okay? Generally, standing posture degrades over time. So you're on a call for a really, really long period of time. You're standing at a, event for a very long period of time. That's when, if we haven't worked those postural muscles the way that they should for a time domain, they will fatigue sooner than if we had worked them. So that's when we'll start to see a little bit of degradation in our posture. And also, a lot of times you see for females, we have a tendency to kind of kick a leg out, pop a hip out, and we'll stand like that. That will, again, create a bit more of a lateral curve and a hyperextension in the low back. So feet underneath you, underneath the hips, underneath the shoulders, and head in alignment is what we're looking for. For our sleepers, okay, if you are a stomach sleeper, my first piece of advice is stop. Go to your side or your back. But for us stomach sleepers that can't, highly recommend a very low pillow and a pillow underneath the hips and the core right through the center, okay? Why is that? So if I'm sleeping on my stomach, naturally, I have to breathe, right? So now I must turn my head. Usually we don't enjoy just keeping our leg straight, so we pop a leg out as well. Now I've closed off this side of my cervical spine, this side of my lumbar spine. I'm stretching out the other side. And in a perfect world where we're sleeping for 8 hours, definitely happens at the station all the time. Okay, but let's just pretend I've now slept in this position for 8 hours every night. You can see how one side's going to get very loose and one side's going to get very tight. Again, tight or overly stretched muscles are weak muscles. Why does that matter? Well, now you're going to look at a lot of radiculopathy pain. That's where we wake up, our hands or fingers have fallen asleep. And again, we're looking at a long-term new plasticity of a new motion or a new position that we're going to be in. This side is tight, this side is stretched. That means we need to stretch this side, strengthen this side. See, again, we're back to some of those force couplets and some of how our posture is going to affect what we're doing. So one side might need to be stretched, one side might need to be strengthened. So again, low pillow, so at least that way we're not causing a lot of hyperextension in the neck, and a pillow underneath the hips and the stomach. You can even place one underneath the shins if you'd like to as well. For my side sleepers, okay, same concept. If the pillow is too high or too low, we're going to get some turn in our, or some lateral bending in our cervical spine. And we have a tendency, because we don't keep our hips stacked and our knees stacked, we rotate and we slide one forward. Easy modification: A, get a pillow that's good for your neck, and B, pillow between the legs. That'll keep your femurs aligned and your legs stacked. And lastly, my back sleepers. We need a good pillow, again, as always. And also, we have a tendency, if we don't have a bolster under our knees, the weight of our legs will pull our hips down, which will cause a lot of hyperextension in our low back. So a little bolster under the knees. The best way to figure this out is get a significant other or a friend or a stranger and have them have yourself get into bed, into whatever sleeping position that you get into, no covers, sheets, anything like that, and get a picture of what you look like, and you'll see if you roll, you'll see if your head is, or your neck is tweaked, that kind of thing. It's usually the best way to do it because we don't know what we look like when we're sleeping. All right, lastly, being seated. All right, we have our picture perfect. We're gonna come back to that, 90 feet flat, and we're straight up and down, right? As we get tired and we begin to slump forward, we're now again creating more curve in our thoracic spine and getting a forward head posture, just as much as if we start to slouch down. Okay, so we don't want these, but I'm gonna put an asterisk next to this. So when we're looking at the amount of pressure that's on the lumbar discs, depending on the position we're in. Okay, in a perfect world, we're laying down, not a lot of pressure on our lumbar discs. Laying on our side, we're standing upright. This is our baseline, because again, we're bipedal. This is our baseline. From there, if I lean forward, I've now created a longer lever, which will increase the amount of pressure on my low back. It's just physics. Longer lever through our fulcrum point, which is our low back. I've now doubled the amount of pressure on my low back if I'm leaning forward and holding weight. Well, then we go to being seated. Okay? We have the amount of pressure if we're seated upright in our 90-90, but we also have somebody who's leaning back and there's less pressure on the lumbar spine. That is because research shows about a 30-degree reclination, or reclining about 30 degrees, 30 to 45, will actually lower the amount of pressure on our low back. Okay? That is different than I'm in my car and I'm slouched down and I'm in my new F-150 or my new Tundra and I've got my Oakleys on and I'm pulling my boat to the river and I'm slouched down really, really far. That is different. This is about 30 degrees, which is what you see a lot of like office chairs that come with just, they recline back just a little bit. So we're still seated back towards the back of the chair. Our feet are both still flat. They're not crossed or anything, they're flat. And we're in a relatively upright position, but ergonomically we lean back just a little bit, okay? So still a little better, about 30 degrees in comparison to straight up and down. Being seated, there's more pressure on the low back than standing because you've taken your legs out of the equation. So now all the force is going directly through your back. From there, if I'm now slouched forward in my chair, we've increased pressure, and even more if I'm slouched forward and holding weight. Now, we generally don't slouch forward and hold weight at the same time, but take the chair out and what does that look like? Poor lifting mechanics, okay? So that is why we talk about lifting and we don't have a rounded back and we use our legs, is because of the amount of pressure on the lumbar spine. Same thing for our neck, okay? Straight up and down. If I start to lean forward about 15 degrees, again, the weight of our head, 10 to 12 pounds, now becomes 27. 30 degrees becomes 40. 45 degrees becomes 49 pounds. 60 degrees, your head now is about 60 pounds of pressure on your cervical discs. Lastly, okay, again, we're going to talk about lifting. I am not just going to tell you to use proper mechanics. That has been instilled in you throughout your entire career, right? But what I will tell you, okay, first of all, brace. That is important because it actually creates a mechanical change. Now, weightlifters put on a weightlifting belt, right? I don't expect you to put a belt on when you go to your calls. What you can do, though, is brace your core. That's not holding your breath, okay? That is tightening up your abdominals. It's also tightening up all the muscles in the back as well. Remember, it's like a cylinder. It's not just the front, it's all the way around. By tightening up your core muscles, we are pushing all of the intra-abdominal contents, so all of your guts and everything, we're pushing down on them, increasing intra-abdominal pressure, which will create pressure pushing back against these vertebral bodies. So we tighten down, we squish all of our insides, they push up against our vertebral bodies. That will create a nice rigid surface for us to not cave in against. So if I wasn't bracing and I went to lift and I use improper mechanics, okay, it's easy for these to give out, which is again how we're going to get back injuries. If instead I brace, and I can brace, I'm currently bracing now but not holding my breath, is that you can brace, push back against these vertebral bodies, which again will keep all of our disc in alignment and everything, and it'll keep us from caving in and having a weak spot. So you want to do abdominal bracing when you when you can. And then also you want to work within a safe zone. So what does that mean? There's 3 things for a safe zone, 3 keys. You want to keep it, the object or the patient or whatever it is, close. You want to get level with it, and you want to pivot towards it. So again, I'm not going to say proper lifting mechanics, but try to remember, get as close as you can to the object or the patient, okay? So we don't, again, want to lift and be reaching far away. Again, it creates a longer lever that's more force through our low back. So you want to get close to it. You want to get level with it, whether that means something's up above and you need to come up to the height of it, or if we're down low, then we need, again, work on good hip and knee and ankle mobility to get all the way down to the ground and be able to get as close as we can to and get level with it. And lastly, do you want to pivot towards it? Twisting and bending is the #1 way to get a disc bulge or herniation. Again, because that posterior part of our back is our weak spot. If I twist and bend, all of that fluid from the disc has to go somewhere. And it is going to come out the side, and it's going to come out the back, and that's how you're going to get a disc bulge or herniation. So you need to pivot, pick up your feet, pivot towards it, and face whatever it is that you're lifting. So again, those are our 3 keys for lifting, is to keep it close, get level, and to pivot to face it, all right? Lastly, our workspace, our ergonomics. That might mean, again, for our captains and our BCs and people doing a lot of paperwork, that could mean getting a standing desk. It could mean getting a little laptop lifter. Again, a good chair that has that 30 degrees of reclining. Even just around the house or around the station. Is there anything ergonomic we could do more ergonomically friendly? So again, am I constantly reaching for something that's not in the best place? Can I move it somewhere else? All of these things, again, add up. It's those repetitive motions that we look at that begin to add up over time. Those micro traumas that eventually lead to that catastrophic injury. So try and see if we can make our workspace a little bit more ergonomically friendly. Always use our 3 keys for lifting. Adjust our driving because we do so much of it now, and think about our posture. Okay, so our key takeaways, again, we use one of our 3 keys to lifting. Use teamwork when you can. I know that, again, is ingrained in you, but back injuries occur very quickly. It doesn't take much for you to have gone to pick something up and next thing you know, boom, there it goes. So you can't really stop just midway once you've already kind of committed to it. So if you think you're going to need some help, then just err on the side of caution. Use teamwork. That way nobody's getting hurt. You need to choose the right modality. So again, maybe that's acupuncture. We're going to start with ice initially, then we're going to go to heat. Maybe you want a TENS unit, maybe you want a Theragun, okay? They're going to be different for everybody, and know how to use them and when to use them. Warm up and hydrate. Again, throw a hot pack on. Do some dynamic stretching before you exercise. Take a hot shower, anything like that. Again, warming up is going to really help with our fluids on top of staying hydrated. You want to take in water. You want to take in electrolytes. Again, it has an effect on our intervertebral disc. It's very important, and it's important for everything else in our body. Stretching and strengthening are going to be our key components. Something might need to be stretched, something might need to get strengthened. Again, my engineers that get out and turn left all the time. I can point you out pretty easily if your left side is really, really tight and your right side is really, really stretched. Same thing with my captains going the other way. Or I'm always getting up on the rig with the same leg, and we see a lot of knee injuries, things like that. Maybe you can strengthen everything and stretch everything, but maybe give the left side a little extra stretching and give the right side a little extra strengthening. We're thinking about if I'm constantly doing this motion, maybe later on I'm going to try and work the other way. So stretching and strengthening are different fiber types as well. Again, if they're going to be more time domain based or if they're going to be repetition and strength based. Our daily activities, and those repetitive movements begin to add up. So really start to be mindful of what you're doing. All these little micro traumas, if it's giving you a vote for good mechanics and good posture, or if it's bad. So if it's bad, then it's going to keep adding up, and then eventually, again, those micro traumas are going to add up into that catastrophic injury that could have been prevented earlier on. And modifications, small things we can change. Again, the way that we sleep, the way that we're sitting, if we've got a little bolster in our back, whatever we can do that, again, extrapolates over time for how many times that we're doing it over our career, over our life. Don't be sedentary. The body is very quick to learn, and if you don't use it, you will lose it. So always stay moving, always keep functional range of motion, on top of the fact that if we're more sedentary, we have a tendency to have more weight on us. Just like an SCBA will displace us back, having extra weight, or like pregnant women, that kind of stuff, will displace us forward. It also creates more load on the spine, more load on the intervertebral discs. So again, don't be sedentary, stay moving. And then injuries are like dehydration, I say. If you're thirsty, you're already dehydrated. If you feel something nagging and aching, then it's already telling you something's wrong. It's going to turn into a bigger problem. So again, always seek medical treatment, whether it's your doctors, physical therapists, whoever it is. Go get something looked at before it becomes a much bigger problem. And with that, we've now gone over the spine in its entirety. So a lot of the programs that Santa offers, our injury prevention program, our STEP program, okay, that's us. That's the physical therapists and physical therapist assistants coming out. Maybe you had an injury and you went to physical therapy for a little bit, and workers' comp cut you off short and sent you back to work early, and you feel like, man, I feel like I need a little bit more strengthening, or I feel like I need a little bit of extra attention. That's where we'll bring all of our stuff, we'll come out, we'll work with you one-on-one to address anything that you need. Nutritionists, okay, we have great nutritionists, Charlotte, I love, who will come out and work with you one-on-one, or a Zoom call. They'll work with your entire station, or your whole crew. Grocery shopping, meal planning, everything. So we have nutritionists available to you. And lastly, we have workshops. So that's our deadlifting, our kettlebells, our foam rollers. We'll come out, we'll show you how to use pieces of equipment, or we will, again, address a particular area of weakness or concern or interest that you guys have. But other than that, my contact information is here. And if you have any questions, you need to reach out at all, I'm always available. And from there, just stay safe and healthy. Thank you.